Good afternoon. My name is Megan Carpenter, and I've been an employee at Inspira Medical Center, formerly Underwood Memorial Hospital, for 10 years. For the past 8 years, I've been working as a registered nurse on 5 East, also known as the ACE unit. I do take tremendous pride in the hospital, and I'm very fortunate to work with a group of colleagues who share the same passion that I have. I sit here today before the Board of Directors and the Medical Executive Committee on behalf of not only myself and coworkers, but also our patients and the community. This is a small community-based hospital, and it needs to continue providing the quality care to the community that it represents. Our community is well aware that the practice of medicine is changing. However, they don't want to be treated like a number. Often, patients, in fact, will tell me they'd rather come to our hospital instead of going to the city because they would rather be treated as an individual and not just a number. So, this individual and quality care does speak very highly of us, yet we need to make sure that it remains. As chair of the Collaborative Unit Council Committee, I am speaking on behalf of our entire nursing staff, as well as ancillary staff and other departments. We all know that no matter what department we work in, we have an impact on the patients. From the first encounter in the emergency room, to being greeted on the floor, and from that point forward, we all create lasting impressions on the patients, and we understand what our purposes are. By this time, I realize that everyone is aware of the Affordable Care Act that was passed by Congress and signed into law by President Obama. Within it, there's a readmissions reduction program that requires Centers for Medicare and Medicaid Services to reduce payments to hospitals with excess readmissions. Currently, they're focusing on 3 diagnoses and looking at those patients who are readmitted within 30 days. These include congestive heart failure, acute myocardial infarction, and pneumonia. Just looking at our CHF readmission rate for this hospital is nearly 40%, which is well over the allowed rate. Already, the hospital has reached its maximum financial penalty allowed for the year at 1% because of these readmission rates. And this penalty is expected to increase by 1% each year until 2015 if the problem is not only addressed, but also fixed. And let's not forget that the information that I just shared with you is public knowledge, so it can be easily found on the internet. I'm sure nowadays patients are doing their research and comparing us to other nearby competitors shopping for the best hospital. And so, how can we reduce the number of readmissions to this hospital, you may ask? There are several ways. First and foremost, I need to have everyone in this room give 100 support of the initiatives put in place today. Now, I'm sure some of you may be sitting there thinking that if your patient comes to the hospital, you must admit them. This is not the case. There are Medicare guidelines and criteria that must be met for the patient to be considered for a hospital admission. Utilize the resources that are available to you. Our care coordination department is extremely familiar with them. If the patient is stabilized and discharged with the appropriate resources, then you have done your job. You not only have a responsibility to the patient, but to the survival of the hospital as well. Let's look at some of the programs that have shown to be successful in decreasing the number of readmissions to hospitals. There have also been studies to analyze why patients come back to the hospital. One of them is the mindset of the hospitalists keeping their beds full. No vacancy means money. Not the case anymore. In fact, more and more of these patients are not creating revenue by being in the hospital, and the hospital would be much better served if they were having their care as an outpatient. We need to establish the resources for our community to be able to promote the new standard of care. By having the financial resources to open, for example, let's say a comprehensive cancer center, then your patients and the community would be better served. The hospital could reach out to our skilled nursing facilities, educating them on such things as low-salt diets and the importance of weighing the patients, primarily those with a history of CHF, and for those people who have had pneumonia, the importance of getting up out of bed, incentive spirometers, making sure they're following aspiration precautions. These are just some examples. If we can keep our readmissions out, then there will be a lot more beds for other patients who need them for acute events, which potentially could mean more revenue for the hospital. The evidence is there to support the development and implementation of transitional programs that put not only the nurses from home care, but also advanced practice nurses and other ancillary services in the patient's home. Medicare is cutting back on reimbursement for these services as well. So therefore, the hospital and agencies must work together to provide a product that will be beneficial to both. Currently, the hospital's CHF team has started a paramedicine team that sends out a paramedic to the patient's home and provides services for the patient as directed by you, the physician, to try and prevent a readmission from occurring. However, I do feel very strongly that if an advanced practice nurse follows up with the patient as well, then this will give more of a success in preventing the readmission from occurring. This is just an example of how our CHF team is looking at the evidence and finding ways to provide more services in the home to enable better patient outcomes. With the money saved by the reduction in readmissions, programs can be expanded to other chronic medical diagnoses. The hospital name will be out there, and people will find comfort and trust with the continued care given at home and directed by their own physician. The resources are growing every day. Many patients will tell you that sometimes they're confused when going through their discharge instructions, or once they get home, they forget what they're supposed to be doing. A hospital in Alabama, for example, is now recording the discharge instructions along with the patient using an iPod Touch device, then downloading it onto the internet. And once the patient is home, if he or she feels the need to retrieve the instructions, if they did forget something, then they are able to retrieve that. And just by changing the discharge process at this hospital, they've reduced their readmissions by 15%. So who's to say we cannot do the same? In my hand, I hold a number of studies that have proven many different successful ways to provide a higher standard of care that is both beneficial to the patient and the hospital. This evidence can be utilized at Inspira Medical Center of Woodbury to develop specific programs to help our community grow and improve. Evidence has shown that putting professionals in the home has yielded better patient outcomes than readmissions to the hospitals. Patients begin taking responsibility for their own care when they are given the help that they need at home. This hospital needs to take on the burden of helping the patients it serves to assume responsibility for their own well-being. The physicians and administrators in this room right now need to buy into what the evidence is telling us. If you don't, then just keep readmitting your patients to the hospital. However, the financial burden on this facility will be too great, and then the community, as well as us, will lose the benefits and comforts of having a small community hospital, and everyone will lose. I thank you for your time today.